Hi everybody, welcome to Dr. Manny's YouTube Learnshops. This Learnshop is about pharmacology, and it's pharmacology for nurses, and this is part 1. There are actually 8 parts. In this session our learning objectives are to review pharmacokinetics, pharmacodynamics, your role in medication administration as a nurse, the methodology that could be employed to reduce medical errors in relation to medications, some of the nursing medication responsibilities, and a quick review of the high alert medications and what that actually means, and just specified medication calculation exercises, and then a knowledge activity review. Okay, before you ever consider medication for a patient, there should always be a therapeutic plan. And basically that means the medication being considered should always include why this medication has been ordered, the appropriateness, the patient's current condition, their age, the state of their health, their past medication history. A patient explanation and understanding must be provided. Implications of the therapy, the objectives of the therapy, the action of the medication, and any possible adverse effects related to the medication being ordered. When we look at pharmacokinetics, there are essentially 5 components. And the 5 components basically mean which affect the relationship between the patient's body, the person taking the medication, and the actual medication. And the 5 components are absorption, distribution, bioavailability, metabolism, and elimination. When we look at absorption, this is when the drugs pass through the gut wall, the intestine. And this can be complete or incomplete. It depends on gastric emptying, presence or absence of food in the gastrointestinal system, presence of any other drugs that might interact if the patient has gastrointestinal disease. They all will affect absorption. When we talk about absorption, there's something called the first pass. And the first pass is when drugs are absorbed from the gastrointestinal system. The first pass means that the medication actually goes to the liver from the portal vein, and they're partly removed from the blood already before they've reached the systemic circulation. The rest of the medication reaches the systemic circulation, and what that means is this is referred to as bioavailability. In the first pass, there's a large removal effect. Oral medications go to the liver, and one of the primary responsibilities of the liver is to clear potential toxic medications or waste products or etc. So therefore some are eliminated and neutralized immediately. An example would be insulin. And as a consequence of the first pass effect of insulin, it requires an alternative route, which we know to be intravenous or subcutaneous. The first pass can have a small removal effect, and this is where IV medications bypass the liver because they're administered directly into the blood, and if they're given intravenously, then you have 100% bioavailability. As we saw with insulin, a small removal effect on the first pass. Then you've got distribution. What does that mean? Distribution means where does the medication actually go? Some stays in the blood, some does not stay in the blood. Some diffuses into the tissue spaces, which could be intracellular or interstitial. Some diffuses into the cells. So you've got 3 sites. The 3 sites basically are in the blood plasma, in the interstitial fluid volume, and in the cell, intracellular. Extracellular consists of the blood, plasma, interstitial fluid. Intracellular is the cell. When we talk about bioavailability, well, bioavailability basically means how much of the medication, the drug, actually reaches the blood after administration. When you have intravenous administration, you get 100% of bioavailability. When you've got oral or gastrointestinal administration, bioavailability depends on the variables that we discussed previously. When we look at metabolism, well, metabolism means what chemical changes occur in the body. The body uses some of the drug and then removes or eliminates the drug. And the drug left, the metabolite, is what actually is removed. So drug can enter the cell and then the drug is pumped out of the cell. In uses what it wants, pumped out the metabolite to be excreted. With elimination, this means how the drug is excreted from the body. And the faster the body breaks down, metabolizes the drug, the more rapid in the fall of the blood levels of that medication, and therefore the more rapid the elimination. When we talk about elimination, we also have to consider two things. The first one is the plasma half-life, and the plasma half-life is essentially the time that it takes to halve the concentration of the bioavailable drug. The time that it takes to excrete the drug from the body. It's the elimination time. So for example, if you had a medication that had a half-life of 10 hours, then after 10 hours, there would be 5% of the medication left. After another 10 hours, there would be 2.5% of the medication left. After another 10 hours, there would be 1.25% of the medication left, and so on. The plasma half-life is the time that it takes to halve the concentration of the bioavailable drug. We also have to consider tachyphylaxis, which is medication tolerance. So when higher drug doses are required to have the same effect, that's basically what it means. When you're on a medication, the body's very clever. The body will try to overcome what the medication is doing. So therefore you need higher and higher doses until possibly the medication isn't having the effect that was originally prescribed for. So a new medication may have to be considered. Well, why does it happen? It happens because the body is very clever, as I said, and it adapts to improving effective elimination. And then another medication may have to be considered. What are some of the factors that affect medication effectiveness? Well, the first is your body size, your age. Look, when you get older, things become less effective, such as your kidneys and your liver, and excretion or elimination may take longer. When you're younger, your metabolic rate is higher, so therefore medication may be eliminated earlier. You've got genetic polymorphism, which basically says that it contributes to your specific genetics or phenotype, and this can be related to drug responses. You've got your nutrition status. If you're malnourished, or if you're overnourished, this can have an effect on medication. If you're fat, or overweight, or obese, or morbidly obese, this can have an effect on the medication, because some medications are hydrophilic or lipophilic, hydrophobic or lipophobic. If you've got an intercurrent illness, this can affect how effective your medication will be. You can have medication interactions, especially if you're on polypharmacy. If you're on a number of different medications, some of them may affect each other and neutralize or potentiate. So it's important that the correct medication is prescribed, and knowing that the interactions between other medications. There are medication administration routes. Well, the most effective, as we said, intravenous, 100% bioavailability. Other sites, such as inhalational, oral, sublingual, transdermal, intravaginal, intrarectally, they may not be as effective because of the first pass effect. What are some of the medication routes? Well, you've got oral, sublingual, intravenous, rectal, vaginal, inhalational, transdermal, epidural, intrathecal. And they all have to be given via the right route. Because if you give intrathecal medications epidurally, this can result in a life-threatening condition. If you give a medication that's specifically ordered to be given intravenously, then it may not have an effect if you give it orally, such as insulin. Oral medications can include tablets, capsules, mixtures, emulsions, or elinctus. Intravenous injections, well, injections can be given intravenously, intramuscularly, subcutaneously, epidurally, or intrathecally. Then you've got other medications that can be given rectally, vaginally, inhalationally, or transdermally. They have to be given via the right route, otherwise they may not be as effective as intended. When we look at pharmacodynamics, we're looking at how do medications actually work. Well, you've got a number of different theories. I've just introduced two. You've got the first one, which is receptor activation theory. And this basically means there is an agonist, a stimulus, key, which is a chemical hormone, a medication that combines with specific cell receptors, and if they combine correctly, it opens up and allows a reaction. So the principle basically is the drug, the agonist, is the first key. It fits into the receptor, which is the first lock. It activates or opens the receptor lock or site, and this acts like a second key to open the second door. It activates or opens the target cell that the medication was intended for, the organ, to increase it, to make it work better, or stop it, to decrease it. Then you've got the receptor lock block theory. And this is an antagonist block. And it's essentially a chemical hormone or medication that combines with a receptor, a lock, on the cell receptor wall. It deactivates, therefore locking it and keeping it locked. And basically what it means is that it blocks the key, the agonist. And I've given you an example here, epinephrine or adrenaline. We need it, it's sympathetic stimulation, and it enters the lock. It has a similar shape to the agonist epinephrine. It can fit into the receptor, the first lock, the receptor, and it stops, blocks the agonist, which in this case is epinephrine, adrenaline, getting to the receptor. And therefore this deactivates, closes the target cell to the stimulus. So therefore this can make it work better, or it can make it work less. So for example, if you have a tachycardia and you have a cardiac condition, then you can give a beta blocker. Beta blocker blocks some of the agonist, epinephrine, from getting to the heart cell. And therefore the heart slows down, it relaxes more, it slows down. And it can make it work better. So with beta blockers, as I said, you take the beta blocker. It goes to the beta receptors and blocks epinephrine, adrenaline from getting to the receptors on the heart cell. and it slows the heart rate down, not too slow, to what's considered a normal rate between 60 and 100 beats per minute. And the heart stays normal and blocks epinephrine. As a consequence, it blocks what is called the fight or flight response. They don't occur. So, what's your role to make sure that the patient gets the right medication? Well, we have something called the medication administration rights, and depending on which protocol you use, there can be anything from 5, which we're going to be discussing here today, up to 18 different medication rights, depending on the organisation that you work for. The first medication right is the right patient. Identify the right patient. And we identify the right patient with full name and medical record number. And this is still one of the biggest medical errors globally, identifying the patient correctly. Full name, medical record number. Then you've got the second right, which is the right prescribed medication. And errors can be made during prescription, so it's preferable to have the physician or the reordering prescriber to write the generic name and to write clearly and correctly. The third medication right is the right prescribed medication dose. No abbreviations are allowed or recommended, and the dose has to be written clearly and correctly, which means the prescriber should know the medication. Then you've got the fourth right, which is the right prescribed medication route. Again, no abbreviations, written clearly and correctly. And the fifth right is the right prescribed medication date and time. When the medication is to be commenced, when the medication is to be completed. No abbreviations, written clearly, written correctly. These are the 5 medication administration rights, but again, depending on your organisational policy, there can be many more. When we look at high alert medications, what are high alert medications? Well, high alert medications, according to the World Health Organization and the Patient Safety Organization, are medications which could cause an immediate life-threatening condition if an error in administration occurs. You've given the wrong medication. Common high alert medications include, and these are just some, potassium chloride, heparin sulfate or sodium heparin, insulin, which are numerous, fentanyl, a narcotic, morphine sulfate, another narcotic, warfarin, an anticoagulant. What are some of the safety precautions that are recommended? And these are again just a few with high alert medications. Tall man lettering is recommended because it identifies the difference in the medication. So at a glance you can see they're not the same. Here's an example: dobutamine, dopamine. Warning labels are a good indicator. When you're using a high alert medication, it's a good idea to use warning labels to alert people that they're using a high alert medication. Depending on the organisational policy, the actual medication is labelled, the tubing is labelled, and the site is labelled. The use of red containers. Red means stop, danger. Green containers typically mean okay. But with high alert medications, it's recommended to put them into red containers and separate them, so that everyone is aware the red containers contain high alert medications. Another important tool is called independent double check. And this means you have two registered practitioners that handle medications, whether they're the physician, the pharmacist, the nurse. And this process allows confirmation that medication administration rights have been employed, and this can prevent medication errors. With independent double check, each practitioner checks the medication using the 5 rights or whatever process that you use. Then they give it to the second practitioner, who does exactly the same thing independently, and then they both come together and say, yeah, this is the right medication for the right patient, right dose, right route, right date, right time, etc. And then the medication can be given. Independent double check. When you look at medication calculate formulae, well, I'm only using 3 as an example, but there are numerous other ones, depending on what you use and what your organisation recommends. Here's the formula. Here's the question. Here's the answer. 20 is divided by 25 multiplied by 10. The answer is 8 mils should be given. You've got an adult patient who's in the coronary care unit, for example, or in the emergency department with atrial fibrillation, and they're in congestive heart failure. Digoxin, 175 micrograms, is ordered. The stock solution strength is 500 micrograms per 2 mils. How much volume should be given to provide the correct dose? The solution is 175 is divided by 500 multiplied by 2, so the answer is 0.7 mils of that dose. Volume should be provided. If we look at formula 2, calculating mils per hour, this formula is mils per hour required, micrograms per kilogram per minute multiplied by weight and 60 minutes, 1 hour, divided by micrograms per mil. That's the formula. So if we have a situation of an infant post a cardiac repair, called a Fontaine repair, and requires a dopamine infusion. The infant's weight is 10.6 kilograms. The IV dopamine required is 5 mics per kg per minute, 5 micrograms per kilogram per minute has been ordered. The stock dose is 80 milligrams. The stock volume is 50 mils, a 5% dextrose. How many mils per hour should be given to provide the correct dose? The correct answer is 5 multiplied by 10.6 multiplied by 60 divided by 1600, so the answer is 1.9 mils per hour. Then you've got a neonate that requires a prostaglandin E1 infusion to maintain a patent ductus arteriosus. The neonate's weight is 7.6 kilograms, the IV prostaglandin is 0.1 micrograms per kg per minute ordered. The stock dose is 250 micrograms or 0.25 milligrams, and the stock volume is 50 mils. How many mils per hour should be given to provide the correct dose? The answer is 0.1 multiplied by 7.6 multiplied by 60 divided by 250. So the answer is 0.1 of a mil per hour. The last calculating formula is calculating micrograms per kilogram per minute or micrograms per minute, depending on your organisational policy. So micrograms per kilogram per minute required equals micrograms per mil multiplied by mils per hour divided by weight by 60. So you've got an adult in intensive care or coronary care in cardiogenic shock. They require a dopamine infusion to increase contractility of their myocardium. The patient's weight is 85.6 kilograms. The IV dopamine is 20 mils per hour ordered. Stock dose 400 milligrams. Stock volume 250 mils. How many micrograms per minute are given for the ordered rate per hour? The correct answer is the formula should include 1600 multiplied by 20, which is over 85.6 by 60. So the answer is 6.2 micrograms per kilogram per minute. What about a child that requires a nitroglycerin, a venodilator, for pulmonary hypertension? The child's weight is 10.6 kilograms. The IV nitroglycerin is 2 mils per hour ordered. Stock dose 10 milligrams. Stock volume 50 mils. How many micrograms per minute are given to provide the correct dose? The correct answer is 200 multiplied by 2 divided by 10.6 by 60. So the answer is 3.7 micrograms per kilogram per minute. So that concludes this Learnshop. So before we do conclude, let's review activity. This is activity 1. Name the 5 components that relate to pharmacokinetics. These are absorption, distribution, bioavailability, metabolism, and elimination. Name the organ which creates a large first pass effect and eliminates most, if not majority, of the medication. The organ is the liver. It has a large first pass removal effect. And this is for oral medications because they go to the liver. Some are eliminated, some are neutralized immediately. Many require an alternative route, such as insulin. Name 5 medication administration rights. The first one is identify the patient correctly. Right patient, full name and medical record number. The right prescribed medication is the second right. The right prescribed medication dose is the third right. The right prescribed medication route is the fourth right. And the fifth medication right is the date and time. What about high alert medications? Can you remember? What are some examples of high alert medications? Warfarin. Why? If given in the correct dose, they can bleed, hemorrhage. If given in an incorrect dose, they may not provide anticoagulation. Morphine, sulfate. It's a narcotic, an opiate. It's addictive. It can cause respiratory depression, respiratory arrest. Similar, fentanyl, narcotic, opiate. Respiratory arrest, possibly hypotension, not common though with fentanyl. More common with morphine, hypotension. Then you've got insulin. This can cause hypoglycemia. Hypoglycemia will cause, if severe, hypotension, a neurological complication, death. Heparin, it's an anticoagulant, it causes bleeding. Okay, that's it. Thank you. As I've mentioned previously, if you found this Learnshop of any value, please recommend it to your colleagues. You can even subscribe. That will give me an indication that these are of some value to you. There are other Dr. Manny Learnshops, as I've indicated. This was part 1. There is still part 2 to part 8, which you can access on YouTube. And note, these are for nurses or for whoever considers them to be of any value. Thanks, and I'll see you again, I hope. Please subscribe. It'll indicate to people that you consider these of value. Ciao.